there we are.
Okay, Alejandro, you can start.
Muy buenas tardes a todos. Sean bienvenidos a esta semana de cierre del Congreso Mundial de Neurocirugía preparado por la UNESCO y la Walter Dandy Neurosurgical Society en honor del profesor Gassi Yazargia. Yo soy Alejandro Arias, soy presidente del Student Intergroup in Neurology Capital México y agradecemos al embajador de la UNESCO y la red PEA UNESCO, Jorge Ramos, quien es chairman de este congreso, por la organización del evento. Asimismo, también agradecemos al profesor Salim Abdulrof, quien es jefe del Instituto de Neurocirugía Abdulrof. También el doctor Abdulrof es miembro fundador del Departamento de Cirugía Neurológica en la Universidad de St. Louis, Missouri, y es presidente global de la Walter Dandy Neurosurgical Society, así también como es presidente de la Sociedad para el Mapeo Cerebral y Terapéutica. Agradecemos también a la doctora Deyanira Capi Casillas, quien es presidenta del Student Interest Group capítulo IPN, del ANSI-IPN, y al doctor Babak Garev, que es presidente de la Society for Brain Mapping Therapeutics Foundation. Es un honor estar aquí con ustedes.
Okay.
Okay.
Okay, Alejandro, thank you for your introduction, and I'll say a few words in English now. So, yes, hello everyone. My name is Natalia Fedorchenko, and I'm representing the organizing committee of the World Congress. We are happy today to have our one more speaker, Professor Giancarlo Perra. So I would like to say thank you to the organizer of this Congress, to Mr. Jorge Ramos, the chairman of the World Congress and ambassador of UNESCO, as well as to the co-chairman, Professor Salim Abdulrauf, Chief Abdulrauf Institute of Neurosurgery and founding chairman in Department of Neurological Surgery, St. Louis University, and global president of Walter Dandy Neurosurgical Society. Also, Dr. Deyanira Capi Casillas, president of the Students Chapter WNS IPAN, and Dr. Babak Kateb, president of the Society for Brain Mapping and Therapeutics and Brain Mapping Foundation, and vice chairman of the World Congress of Neurosurgery. And also we have an honor committee is Professor Nasser El Gandour and Professor Marcus Rota. So today our speaker is really welcomed, Professor Giancarlo Perra from Italy. He's going to give us the talk from the history of aneurysm surgery and a brief history of a long journey, like you can see on the screen. Professor Perra, he's working in private and interested in brain revascularization with Brain House, and actually co-president is Professor Renato Saenta. So, Professor Perra, you can have your time and tell us your brief history of a long journey.
Okay. So I'm very happy to be. Is okay?
Yes, we can see you. You can continue, please.
Okay. I can speak. So we go to talk a little bit about the past, present, and the Bayesian intracranial aneurysm surgery, the evolution of surgical technique bypass. The aneurysm surgery starts from a strong will to find a solution for a very difficult pathology that can be affected everybody. The first thing is to say is the subarachnoidal hemorrhage is characterized by bleeding in subarachnoidal space, and often is due to the rupture of an intracranial aneurysm. We find aneurysm in 5% of population, but only in 2% annually we do respond to spontaneous rupture. The history of a nation can be changed by ESA because even the leader of a nation can be affected. For example, in this moment, the president of the USA was operated by two eyes for aneurysm, for a bilateral middle cerebral aneurysm in 1988. But in this case, the Japanese was the General Yoritomo, was the shogun of the army in feudal Japan. And he fell down when he was 52, and after 1 week, he died because of a subarachnoid hemorrhage. So the history of Japan changed after this history. Maybe this gave a most appropriate way to avoid death of severe morbidity after this problem. The first verified evidence of intracranial aneurysm was in Padova by Giambattista Morgagni, who was the first medical anatomical practitioner that described the spread of a posterior branch of both carotid in 1761. After that, in 1765, Biumi from Milano was the first to describe the morphology of a broken aneurysm during a case of death. So for the first time in 1765, we demonstrate that you can be dead after a rupture of an aneurysm. For many years, the things were quiet, and the first attempt to treat with the surgical therapy the aneurysm is because in 1885, Victor Ousley, it was a creative genius interested in stereotaxis, working against the alcohol, tobacco, and very active in politics. He tried to, like Hunter did said before, to close the carotid at the neck. And then with this, it can cause the thrombosis of an intracranial aneurysm. He tried this for the first time in 1985. After, in 1927, Antonio Egas Moniz was a Portuguese, and he put inside the artery the torotrust, the very toxic mezzo di contrasto, so he can design the artery. And then for the first time we had the evidence of an aneurysm in vivo. And then in this case, we can see also the branch, the parent vessel, the perforator. We can have an anatomical review about what is really an aneurysm. Antonio Egas Moniz in 1949 had get the Nobel Prize for the leucotomy, bilateral leucotomy. Angiography was important to collect the data to know the right way to treat the aneurysm. In these pictures, a Sicilian indicates the good pathway to an American soldier at the end of the Second World War, because you know the way and then you follow the route and then you arrive to have the results. After the angiography, we were able to have a goal. The goal is to be able to isolate the sac of an aneurysm and take it out, preserving the function of the parent vessel. In this case, in 1917, Harvey Cushing, during an operation of pituitary gland, found an aneurysm, and the only thing he can do in that case was to close the carotid artery. The patient died very quickly. In this case, Harvey Cushing, in 1926, Hervé attempted a rudimentary trapping of carotid aneurysm using muscle tissue. The patient developed hemiplegia and subsequently died some days later. After this experience, he said that a lesion having such a remote cervical bearing, whether there are surgical indications, such a ligation of internal carotid filter experience only can tell. He didn't believe in an evolution of surgery for aneurysm. Kashi was responsible, also was the first one to use the silver clip to try to close an aneurysm. But something is changed. In 1968, the Dr. Norman Dot, that had an accident when he was young, and he was a key figure in the art of aneurysm surgery because he first tried to make a therapy. The therapy was to wrap a muscle around the aneurysm so to reinforce the wall. At that time, he was a pioneer because the only therapy for the bleeding, subarachnoid hemorrhage, and aneurysm was the lumbar puncture, because they thought at the time that taking out the liquor, it is easier. There is a thrombosis inside the aneurysm, and then you can treat in this way. But the rate of failure was very high. So he tried, starting from a consideration, they had a very, very bad bleeding during operation, and they had hemostasis using a muscle, and he tried to treat the aneurysm, putting a wrapping with the muscle. But this so-called passive strategy had a high failure rate. And then after many years, Norman Dot left Franz Gerlingan with the task and continued the research, and saying that for him was the time to grow his roses, because thought it was enough. The patient they treated first, Norman Dot, was Colin Black. Colin Black had 3 times the hemorrhage. And he was also the director of Royal Hospital for Sick Children. And without any hope, Dot spoke with the wife and the patient about the possibility to do a wrapping of the aneurysm. The aneurysm was originating from the middle brain, bled during surgery, and Dr. Dot swabbed it with a fragment of muscle for 12 minutes, and then covered the middle brain with muscle for the first 2 centimeters. Finally, he performed a subtemporal decompression, and all this was in 3 hours and 40 minutes. The patient had a poor outcome. But Dot was the first that tried to do a good therapy for the aneurysm, a correct therapy. But the first one that clipped an aneurysm was Walter Dandy. And Walter Dandy in 1937 was the first to operate an aneurysm using the V-shaped, not malleable, and not reopenable clip. The patient was 43 years old, was a melancholic patient, and was operated without angiography just because he had a palsy of a 3rd nerve, so they thought it was the posterior communicating artery aneurysm. He did the operation doing like a pituitary tumor with a subfrontal approach. Subfrontal approach, and it was favored for the very marked cerebral atrophy. The aneurysm has a small neck, and then was able to exclude it from the circle using this clip. First aneurysm clip was so in 1937 with the Cushing silver clip. This is the case, the man, the face of the third nerve on the right side, and then is the pictures that show the procedure. The results. Walter Dandy in 1944 published the first series of aneurysm and published the book Intracranial Aneurysm. He did 133 aneurysms, 64 operates, and 44 autoptic. And he had in 36 cases operate, he had a mortality of 25%. He treated 70%. At that time, it was a very good results. After then, we must go to Sweden with Oliver Krona. Oliver Krona modified the silver malleable clips, not reopenable, with the adding openable blade. And this innovation allowed the clip to be reopened and repositioned if the closure was not optimal. But this clip could tear the aneurysm neck. And Oliver Krona was the first to operate a posterior circulation aneurysm. This is an example of the clip used by Oliver Krona. But the evolution of a modern clip was because of Schwarz and McFadden clip. The genial idea was to invert the blade so you can use it with only one hand. And this was taken from the forceps used in 1840 by Joseph Carrier for the forceps for obstetric. In this case, you can use it with the one hand when you grip the blade are open, when you relax the blade are closed. And then help you, so with the one hand you can have an aspirator and another one you can take a clip. The clip applier was modified in 1952 by Mayfield. Mayfield he reduced the size of the blades as much as possible and create the clip with 15 millimeters only. Charles Drake was the first to do a longer series of aneurysm in the posterior of basilar and posterior circle aneurysm, and he used a lot the ring clip. It was a new way. He tried to insert a ring between the blade in order so he can preserve the perforator. He can preserve the perforator. That no one perforator in a basilar system can be sacrificed because you lose the patient. And the Drake did many, with the success, numerous, many aneurysm of posterior circulation, contributing to the development of the subtemporal approach to exclude this aneurysm from the circulation. He did all this without microscope. But the work of Drake was taken by Professor Ernest Niemi. This is the Drake position for subtemporal approach. He did all this with a lumbar puncture, taking out at least 100 millimeters of liquor, and then they retract the temporal lobe without injury the same. He is the greatest depository of this technique and boasts a case history of over 1,000 operated posterior circulation aneurysm, many of them with the subtemporal approach using microscope in the last 30 years. The evolution of material sleep and advanced inert anesthesia have made it possible. Because we must not forget that at the beginning it was very hard to operate. The aneurysm because of anesthesia and the cranial hypertension and everything. After Drake, but more or less in the same age, the Professor Yazari started to use the microscope. And the anatomical consideration was in 1734, Dr. Silvius de Labo, it was the first in history to discover that the sylvian fissure can be opened, and then you can expose and get access to both polygon of wheel system at the base of the brain. Incidentally, probably was also the original recipe of gene. Professor Yazargil used this particular aspect of the brain and tailored the surgery under a microscope using the pterional approach and opening the sylvian fissure under a microscope. He assessed the base of the brain respecting the anatomy. Using a micro instrument, he was able to clip many aneurysms with a surgical procedure. But Professor Yazargil, when he retired in Zurich, but maybe he said exactly the thing that Dot, he was not ready to smell the roses. Dot said, I'm ready to grow my roses. In this occasion, I have also friction of the voice when he's doing, saying these things. So with the under microscope and allowing the definition of anatomical structure, better tools and better results, this is still used Yazargil clip and all the device for the clip applier. But the Professor Yazargil is not only someone that give the aneurysm. He made also a disciplinar to make an aneurysm. He started with the consideration you can do a pterional craniotomy. You must put the hand in a mayfield, rotate from 30 degrees and with a gain of 15 degrees. In this case, the orbitozygomatic process must be the higher point of the, the operatory fields. And this helps the gravity to relax the brain and for the access subfrontal. We did also saying that you must put 4 holes and you must take care for the K-hole. And then after that, you must open the sylvian fissure that take 20 minutes. And then you arrive following the subarachnoidal space until and open the optochiasmatic cistern, and then you follow, for example, for anterior communicating aneurysm A1. If necessary, you can open lamina terminalis to have a more relaxed brain, and then put temporary clip in a way you can take out very easy. And then after peel the aneurysm and avoiding all the vessel and the parent vessel around, you can put a safe clip at the base of the aneurysm. It's a job, it's an incredible job because he did all this alone and studying with a very strong will, and there is also a great humanity to try to do this. It's not only for ambition. But how he arrived at this conclusion? This is Professor Yazargil. You must know that you can say something very good, not from what you know, but from what you don't know. So in an unexpected situation, you must tailor a new approach using your instinct. And then this is in a moment, oblique mentality, I call it. So if it's very difficult to go from A to B, so you do a deviation from C, and then you arrive to B. You arrive to B. And then you must be always ready with the head to change and then be creative. This is one of the things I learned from him. Professor Yasser is always available for everything. For everything you ask, he's like a musketeer. He's one for all, and all are for one. This is Professor Yasser when he was in the army during, I don't know when, and he's a model for many fellows follow his step. We had the opportunity to talk with the Professor Yasagil in St. Louis, Little Rock is an extraordinary attention in everything he realized. Is always giving, and still is interested and involved in neurosurgery. This is all the possibility that you can use a clip, different strategy, but the goal is to clip the aneurysm and avoiding the parent vessel. And then you can use many, this is a reinforcing clip at the neck for many different. This is the evolution of pterional craniotomy. We have the evolution is a mini pterional, orbital, superolateral, and it is possible because the instrument, the anesthesia, can get you easier access to the aneurysm even with a smaller craniotomy. But in many cases, it's different. A lot of work has made, for example, in the evolution of the clip and clip applier. This is a design I found where a surgeon, maybe Mura from Santiago, designed all of these things. It is difficult to read, but it's right. Try to leave this. Try to this one is smaller. And then, because you must arrive in a small space, and then you need a visibility. And the visibility is to micronize the instrument. This is other kind of clip, Sujita clip, are very famous because they play are more, can open more than the Yassergil clip. Following the step of Professor Yassergil, in Italy we had the school of Professor Dapian. And then you can see how...
Renato, qui bisognerà fare un lembo in maniera da poter approcciare l'aneurisma sia dal davanti che di lato, tenendo presente che può essere anche un pochettino più grande. Ora il lembo è pronto e andiamo con il microscopio ad affrontare l'aneurisma. Tutto il microscopio che ha un dispositivo mediante il quale può essere mosso con la bocca.
So you can move, and the pipe mouth is something extremely important for the microneurosurgery because it permits to be very around the table and have always two hands inside the operatory fields. Many complex aneurysms and the study of cerebral flow, you can use a bypass in a complex aneurysm. And then this is the school of Chicago with Professor Charbel. And in China for Moya Moya, is a Professor Bing Su, who is a man that do every year a lot of many bypass for Moya Moya disease and also complex aneurysm. The study of cerebral flow is extremely important because because the future of anatomy is in a flow. And then this is the revascularization, where there is many gray zone, the Moya-Moya syndrome, and we are always studying this problem. This is a vertebral aneurysm that we treated with a pica anastomosis that you can see a little bit now. I don't know why it doesn't work the piano. And the future of the neurosurgery is a concept of endovascular. In Chicago, they did an aneurysm. Education in aneurysm surgery. In this moment, we have on a webinar many webinars that talk about how to do correctly an aneurysm. Achieving master in aneurysm surgery with the cooperation with Professor Lawton from Barrow Institute and Professor Chris for Arkansas Neuroscience Institute. In the case of complication, for example, you say that you must control your visceral response and calm, clarity over time, okay? And for example, in an Aneurysm mentality, in case of a complication, try to transform a ruptured aneurysm into an unruptured one, and then you can reconstruct the base and put a safe clip. The surgeon must have the hands of a warrior and the head of a Zen. So this is what Professor Scienza said many times. We must share all the information to obtain better results in less time. We must be like an astrophysics, looking for alien life. This is the European Consortium Very Long Basilar Interferometry. They are taking data from the sky. And this is a group of scientists, like this group of neurosurgeons that we were in Helsinki some years ago. Our contribution to Italian School for Surgery was doing for many years during a brain house that we did in Padova with a liver surgery. And many prominent neurosurgeons came there and they did very great operation. We have Professor Ernest Niemi, Professor Ali Christ, Dolen, Evandro de Oliveira, and all in a safe place with We had also great results, great time, and was the only Congress that no people was going to hit, because they were all interested to see the screen and the news that we were saying every day. I think the brain aneurysm surgery is just the beginning. Collecting more data about the capacity of recovery in the brain will provide a slow explanation, in many cases considered to be inexplicable. Aneurysm surgery is a noble art, and we must not lose that. This is a case of a 4-5 Hunter S grade scale of a basilar bifurcation aneurysm. The patient, you did all in a perfect way. You avoided the perforator, like here you can see. And then after 46 months, she awake, sang and singing a song, 46-8. It's not so normal, but it means that we must collect more data. Maybe the grades on are more expanded than what we think. In the modern aneurysm surgery, age is not a limiting factor anymore. If the general conditions are good. This patient was operated on in 2007 for an anterior communicating artery aneurysm. At the time, she was 89 years old and survived in good condition for a long time. She survived at least until 2012. I don't think he's still alive. But so what's the future of aneurysm surgery? I think Professor Yasa established a discipline of the material, and then all the principles he did are still correct. You can do in different way. Exactly our proposition is like classic music and then new way to perform, like this. Performance songs are completely made in jazz. The performance is different. Live. This is the landing, and thank you for your attention.
Thank you very much, Dr. Giancarlo, for this wonderful presentation. Dr. Natalia, are you there?
Yes, thank you, Dr. Giancarlo Perra. It was really interesting. I mean, the history of
a short excursion, because there is so many things to say, but it's not.
Yeah, you can do a set of webinars, to show all this stuff, because it can't be put just into one presentation. I'm sure about this. Generally,
I try to make a concentration of notion, but what is important for me is the strong will and the humanity at the base of the subject. And my message is that I hope this is a art that are not going to be loose, because endovascular treatment is too large in this moment. And in Italy, for example, in the last 3 years, many people do endovascular because of and are not able anymore to perform in correct way an aneurysm. So it's important these two.
Yes, it's a history. Like, if we don't know our history, we don't deserve our future. So the history of neurosurgery is the future of neurosurgery. It's definitely like, and you are one of the people who making the background for this. So like, the possibility for the future generations to land in, it's like due to the people who produced the ground for them. And that's really amazing. So we really wish you to stay healthy in this difficult time, like pandemia, to continue educate younger generations and to being able to share your knowledge and experience. Like, this is really great opportunity.
I can send you also by link the presentation. So maybe
you can see my phone number in the chat. So
no, send me by a messenger, and then I send you the link by Google Drive.
Okay, no problem. I will send you my email so you can share this.
We are very happy if you use it for the education, but is a story very incomplete, but at the same time it must be known, because it's very difficult to arrive